You finish treatment, and within weeks, the bloating is back. The problem isn't you, it's the model. Real healing means restoring the gut's protective systems, not focusing on killing bacteria. If you've tried all the professional protocols and you still struggle with SIBO, this video is for you. You've tried antibiotics, maybe even natural antimicrobials like oregano or berberine, and for a few weeks, maybe even for a couple of months, you felt some relief. But then the gas, the distension, the embarrassing bloating, it all comes rushing back. Well, today I want to explain why the antibiotic model, even the natural version, is built to fail and what you actually need for lasting relief. But before we get into it, allow me to briefly introduce myself. I'm Dr. Arland Hill, and for over 20 years, I've been helping first-time and recurrent SIBO sufferers restore their gut function by targeting all three phases of the condition to resolve symptoms in a timely manner. Let's talk about why killing the bacteria isn't enough. Antibiotics and even antimicrobials can lower the bacterial load. And that's what's often thought about as phase 1. Sometimes there is no conversation beyond phase 1, but just focusing on killing the bacteria, killing that overgrowth, that isn't a plan. It's really at best a pause button. And unless you address why the bacteria overgrew in the first place, your relapse, it's inevitable. It's not a matter of if, it's a matter of when. Keep in mind that there is a vicious cycle that's playing out here where it's kill, get some relief, and then you relapse. Kill, get some relief, and then you relapse. That's not the scenario you want to be in. You want to reduce your overgrowth, get the relief, and prevent the relapse. That's what we're looking for here. To accomplish that means that we need to pay attention to the three protective mechanisms that inherently prevent you from developing SIBO in the first place. These are going to ensure microbial balance. These are inherent mechanisms, and when they're overwhelmed, when they're insufficient, or just even outright absent, that's when the potential for SIBO is going to escalate. What are we talking about here? Let's begin by looking at your digestive secretions. This is the first category. Remember, there's three protective mechanisms, and number one is going to be your digestive secretions. Within digestive secretions, we have stomach acid. Stomach acid is also called stomach hydrochloric acid or just hydrochloric acid. There are many things can impact your hydrochloric acid production. Some of the most common ones are going to be proton pump inhibitors, your acid-reducing medications. Logical, right? But remember, when you feel like you're having reflux, you're dealing with heartburn and you're reducing that acid, you're also negatively impacting that first defense system from the development of an overgrowth in your small intestine. Something else that can impact this are gastric resections. So if you're thinking about weight loss surgeries are notorious for this because they change the dynamics, they change the base physiology, the structural physiology of the anatomy and physiology is how I should say that. They change how that functions, and as a result of that, you lose the ability for adequate acid secretion. And you can also simply have something called atrophic gastritis, where the tissues of the stomach, the acid-secreting tissues, become dysfunctional. They don't have the capacity to develop adequate amounts of acid because they are literally deteriorating. They're weakening and shrinking in size, and they just become non-functional as a part of that. But that's just the acid. Acid is not the only secretion we should be thinking about here. There's others that come into play. Next on the list is going to be bile. Well, what are things that would cause bile production to be low and that would open the door for SIBO to manifest? How about things like non-alcoholic fatty liver disease? This is often talked about as NAFLD. Many times, slight elevations in liver enzymes can be a signal for this. Individuals that see spots on an ultrasound of their liver, if there's a metabolic issue where blood sugars tend to trend higher, of course, alcohol. These could all be things that could be associated with non-alcoholic fatty liver disease. And actually, I guess I should separate out the alcohol there, because that would be alcoholic fatty liver disease. But blood sugar issues would be one of the non-alcoholic fatty liver disease rationales. The point is that it's going to reduce the bile salt production, and these bile salts, what I just simply termed earlier bile, well, these directly have an antimicrobial effect. Nutrient deficiencies, if you have a low protein intake, you'll lack in things like taurine and glycine. These are amino acids, and as a result of that, that's going to decrease the production of bile acids, because these are necessary for bile production. Low thyroid function, you may think in terms of hypothyroid here, but low thyroid function can be a factor in this. There's certain medications because of the impact that they're going to have on the liver. And look at how all these are interconnected. When you have low stomach acid, inherently stomach acid triggers the release, it triggers the gallbladder to contract. And when the gallbladder contracts, it releases bile into the small intestine. If you don't have adequate acid, you don't get a firm enough contraction of the gallbladder, and you don't get that secretion of bile into the small intestine. Low fat intake, you need adequate fat intake to trigger as the inherent dietary stimulus to tell you to dump bile in. That can be a problem. Slow motility, I'm going to come back to that, just meaning that things aren't moving through your GI tract as fast as they need to. Estrogen dominance, when females have too much estrogenic activity, too much estrogen activity, that becomes a player, and it has a direct impact on the gallbladder and the ability to secrete bile into the small intestine. And I mentioned a bit earlier the insulin resistance, the obesity, that ties back into the non-alcoholic fatty liver. And here's the shocking thing maybe about this is that these are just a few. These are not all the reasons that you can suppress bile production. These are just a handful of reasons that can impact bile production. So we've got acid, and these are all under digestive secretion now. You've got acid, you've got bile, you've also got pancreatic enzymes. Pancreatic enzymes produced, as the name implies, from the pancreas. If you have an insufficiency, those act as a defense line as well. So just like with acid and bile acting as defense lines against bacterial overgrowth, well, we see the same thing when it comes to the enzymes. Stress, if you're in a sympathetic state, you're in a chronic fight or flight state, you're activating your sympathetic nervous system all the time, that's going to decrease pancreatic output. Liver dysfunction decreases pancreatic output. And there's a list of other factors that can come into play here as well. But these are going to open the door for that overgrowth. And now as you're thinking, okay, I got rid of the bacteria, but did I address any of the things that I've talked about up to this point? And if the answer is no, well, you're almost surely on a path for a relapse. What about the immune defenses? You have what's called mucosal immunity. So you have the mucus that lines the gastrointestinal tract. And within that mucus, that is part of your immunity, not just locally in the GI tract, but over the whole body. It influences the immune system throughout the whole body. But locally within the GI tract, we have something called secretory IgA. Secretory IgA is going to give us a direct reflection of the immune system and whether it's in a state of suppression, if it's exhausted. And if that is the case and you don't have those robust localized immune defenses, then the bacteria are going to start to overwhelm the small intestine. Things like antibiotics, chronic inflammation, autoimmunity, chronic infections, not getting adequate amounts of sleep, chronic stress, whether that's psychological stress or physical stress. If you're not consuming adequate amounts of protein, that'd be a macronutrient. If you have micronutrient deficiencies like vitamin A, vitamin D, vitamin A especially here is so important with this secretory IgA. What many would think about is your omega-3s, your essential fatty acids, the EPA, DHA. Those are very critical. If you have low butyrate, which is a short chain fatty acid, this is something that is a byproduct of adequate fiber intake. That can open the door for having low secretory IgAs, hypothyroid again, and even some medications. If you think about medications that can have an immune suppressing effect, things like corticosteroids, maybe you've got a cortisone injection, just as an example, or some of the biologic medications that can be used with autoimmunity. These are all going to open the door to have low local immune defenses. And this is essentially the reason that all of these are a problem. If you're lacking the acid, the enzymes, the bile, or the immune defenses, these are all going to create an environment where the bacteria that are overgrowing in the small intestine have no opposition. And if they have no opposition and they have a constant food source coming through, well, what do bacteria do? They proliferate. And as they proliferate unopposed, they overgrow, or they manifest into a state of overgrowth, and that's what you perceive as small intestinal bacterial overgrowth, and in turn, what you also acknowledge as related to your symptoms, the gas, the bloating, the distension, maybe the change in the motility in the bowels. If you've got some IBS type symptoms, even though IBS and SIBO are two different conditions, they do have a lot of overlap between them. These can all be indications of lacking these digestive secretions or lacking these immune defenses. But keep in mind, I told you that there are 3 protective mechanisms, and what I've given you up to this point, well, that's just the first. Well, what about the second one? Well, motility is the second component that can be a protective mechanism when it comes to SIBO. This is generally governed by what we call the migratory motor complex, and it's a sweeping motion that sweeps bacteria out. It's often termed the housekeeping effect, if you will, because it's sweeping. But when you have a breakdown in this sweeping motion, when it's not running efficiently, and that can be a byproduct of too frequent a food consumption, it can be a byproduct of having damage to the nervous system in and around your gastrointestinal tract, what's often termed the enteric nervous system. And that can be subsequent to things like diabetes, opioid exposure. You could have the dysbiosis, the imbalance of bacteria in your gut is actually a precipitating factor to that as well. Those are all going to cause that sluggish activity, and the more sluggish the bowels, you don't get that natural downward sweeping motion going from the small intestine to the large intestine. That's where the bacteria start to settle in, and this is also where your relapse rates start to skyrocket if the motility isn't restored. You can literally see the relapse happen within just a couple of weeks if you don't have consistent motility, or if the motility is not optimized. You'll also hear this talked about as what's generally called peristalsis. So peristalsis would be that natural motion, that muscular fasciculation, if you will, that keeps food moving from through the small intestine on down into the large intestine. But when this is not working adequately and you have dysfunction of this migratory motor complex, this is where you get into something called retrograde peristalsis. And it's literally like things are moving in the wrong direction, and that keeps these contents in the small intestine too long. In addition, you can have the breakdowns in your, you can have obstruction. That can be some type of pseudo obstruction can be a problem here. And then you can also, things that are otherwise going to lead to motility problems, things like neuropathies, literally, again, damage to the nerves that are in and around that area. There's a lot of things that can potentiate that. Diabetes can be a factor there. Autoimmune conditions like amyloidosis or scleroderma can be a factor there. Sometimes drugs, your medication, this is a side effect of some of the medications. Parkinson's disease, where you don't get the adequate dopamine stimulation into that environment. These can all be factors, and that's not an exclusive list by any means. Those are just things that you need to be aware of, that if you don't have good motility, you should be asking yourself, is one of these correlated with my suboptimal motility, and is this the underlying factor that's driving my SIBO relapse that I keep just falling back into when you don't have to? Now, number 3 on our list here of protective mechanisms, and this is probably the most simplistic, but it's also the one that is the most inherent, and that's just our anatomy, guys. If you have some type of structural change, if you have scar tissue, if you've had a resection, meaning you've had some part of your gastrointestinal tract removed, especially when it comes to the stomach or the upper small intestine, where you get those optimal secretions, or if there's something that has changed the immune environment with removal of a part of the GI tract, diverticuli, these outpouchings that can occur, some other type of surgical intervention, anything that potentially changes the anatomy, that can open the door for SIBO. And if that describes you, what you need to recognize is that you are going to have to be more attentive and possibly deal with ongoing use of antimicrobials coupled with rebuilding or re-implementing whichever component that I've already prior talked about is being affected. So for example, if something is impacting your stomach acid production, you may need to use some supplemental betaine hydrochloride to overcome that. You have to be able to make up that difference in what your body can no longer do if you expect to be able to keep SIBO at bay for an extended period of time. When you're creating hiding spots or when you're changing those environments, bacteria love to hang out in those spots that are a byproduct of these anatomical changes. When you change the anatomy, you can start to literally erase some of these antimicrobial components we've been talking about, and that allows the bacteria to start to build up in those regions. You're removing the protective structures or even some of the secretory structures that create some secretions that promote they inhibit, it's a better way of saying this, they inhibit the development of SIBO. You've lost those. So what's a functional roadmap here, right? That's really where I need to take you to. Like, how do you truly navigate SIBO? And I want you to think now beyond this antimicrobial phase. Stop asking the question, which antimicrobial is the best antimicrobial to deal with SIBO? That's the wrong question. And the more you keep asking that question, the more you're going to keep dealing with the relapses of SIBO. If you keep asking that question, don't expect SIBO to go away permanently. You have to think beyond what is the best antimicrobial that I can take. A good combination antimicrobial deployed effectively over a month time frame, over a 30-day time frame, is going to get the job done for the great majority of individuals out there. It is the work that takes place beyond that that is the difference maker. So with that in mind, this functional roadmap of how you should be thinking through SIBO from A to Z is that phase one, maybe I should say from phase 1 to phase 3 instead of A to Z. Phase 1 is that, yes, you do need to reduce the overgrowth. That is important. You can do that with antibiotics. You can do it with antimicrobials, but you've got to do this part because that's dramatically going to shorten the time to resolution. And all of you are looking for that if you've been struggling with SIBO. Now that you've accomplished that, do not stop here. Keep going into phase 2 and phase 3. Phase 2 is restoring the protective systems. When it comes to motility, optimize the motility in your bowels. Think about your lifestyle. Think about the things that are slowing down and that can speed up your motility. You have to look through those. The secretions, your acid, your bile, your enzymes, your immune function locally in your GI tract, and then just your basic anatomy of your gastrointestinal tract. Do I have something that has altered that basic anatomy that I need to identify as a red flag? And do I need to be partnering with whoever's helping me design my protocols? Do I need to partner with them to figure out what the best intervention is going to be for me long term to keep this dysfunction from taking control of my gut? This change in anatomy, do not let that override how your SIBO is allowed to manifest, right? You have to compensate for these changes in your anatomy. And the third thing, phase 3, if you will, is anytime you are dealing with SIBO, and in fact, one of the defined characteristics of SIBO, and that is stated in multiple studies, one of the defined characteristics of SIBO are nutrient deficiencies. It is a nutrient deficiency. There are multiple nutrients that come into play here. You need to isolate what your personal nutrient deficiencies are. Lab assessment can be your best ally to accomplish that. And once you figure that out, then you need to correct those. Correcting those nutrient deficiencies is going to speed this process up. Let me just give you one example. Vitamin A is you have an increased likelihood of a vitamin A deficiency in SIBO. Deficiency in vitamin A is also one of the factors that causes a reduction in secretory IgA, which you need to optimize your mucosal immunity. So it's very important to replace these nutrients. Now, think through this, because I don't want you to fall into the relapse rate where approximately 43 to 44% of individuals within 9 months have relapsed. That's just what the literature says. My observation and the observation of multiple other professionals will tell you that it occurs much faster than that. Antimicrobials are the start, but do not look at these as the solution. Phase 2 is where lasting relief is absolutely going to begin at, and phase 3, well, that's going to finish the task. So the real issue isn't how to kill bacteria, it's how to protect your gut so they don't take it over again. And this connects directly to the number one diet mistake that I see SIBO patients make repetitively. If you want to avoid it, well, watch this next video. The number one SIBO diet mistake to avoid, the FODMAPs diet.